Okay, Karyl Scott is my wonderful colleague. She's a registered respiratory therapist and sleep technologist. She's a corporate manager, clinical manager at ResMed. She speaks all over the country, nationally, regionally, states. She's been 18 years working in home care, ventilation, and sleep. She's originally from Florida, and she has 10 grandchildren. So, welcome, Karyl. Thank you, sir.
Put this in your pocket. And you're ready to go.
Okay. Thank you for having me. It's a pleasure to be here. So I am a native Floridian, moved here about 10 months ago, and all 10 grandchildren are on the East Coast. So I have to say, yes, I'm extremely happy, and I'm extremely homesick. So let's go. For the time that we have left, the topic I was provided was, well, a lot of times there's a question about algorithms, how the different devices work, and interfaces. And then it was, well, we have patients and we have clinicians. So I was thinking about what would be the most helpful. And one of the things I started with, so we can make it go here. No?
Try the space bar.
Which?
There you go.
Well, I did it manual. I can do that. Okay. So you've had some great questions today about indicators, and I think one of the things I've taken away from today was, hopefully, if you realize you can have a lot of different things going on in your body. So it's not just post-polio, and it's not just obstructive sleep apnea, or it's not just central sleep apnea. It's not just cardiovascular disease. There's a lot of things that go on with your body. So if you have any of these symptoms, we talked about them earlier, both of our physicians mentioned them earlier, the headaches, excessive daytime sleepiness. We talk about body mass index, and you saw some great slides of portion control that we have here in America today. So we could have all these things, the snoring, high blood pressure. So those are all just indicators that potentially you could have sleep apnea, obstructive sleep apnea, so you've got the blockage, it's mechanical, and maybe if you have some of those problems, you would probably want to be screened to see if you need to have a sleep study. When we talk about central sleep apnea, the neurological part, so the brain's just not telling us to take a breath, but we still have that open airway. Well, what are some of those symptoms? And Dr. DeMaria talked about the cardiovascular disease and fatigue. A lot of times with patients that have heart problems or cardiovascular disease, they're very tired. So they don't think of themselves as sleepy because they've learned to adjust to the heart failure fatigue. So they're going along, and maybe their daily routine now has become, well, I get up in the morning, I take a nap, then I have lunch, I take a nap, I have dinner, I take a nap, and I go to bed. But no, I'm not sleepy. So there's a difference in how we talk about things sometimes, sleepy versus fatigue. If you're falling asleep at red lights, or you're falling asleep while you're watching TV, or you're falling asleep in the middle of your husband's dissertation at dinner, all the ones before that, maybe you need to think about it. We've got a problem. But central sleep apnea, brainstem injury, medication. So when you're talking about pain medications, those can cause you to have central sleep apnea. So it's definitely worth talking to your physician about all the different things that are going on in your body, because it's a very delicate mix. And it takes not only the physician who has been well trained and well versed in what's best for you, but it also takes you as the patient. It's your responsibility to talk to him and let him know, hey, I think this, because he's not with you 24/7 or doesn't know what's going on with your spouse 24/7. You need to help him and be the eyes and ears at home. So those are just indicators. Traditionally, the gold standard is to have a sleep study in the lab, and that will determine your pressure. If it's OSA, typically CPAP, so that continuous positive airway pressure, is the treatment of choice, but it can go to bilevel for OSA if the patient has OSA. What if you have obstructive sleep apnea because you're someone, I'll just use myself as a model, but you have a short, stumpy neck and you have that adipose tissue going around your belly, but you also have a hypoventilation problem. CPAP's not good for the hypoventilation problem, but bilevel is, and bilevel treats the OSA as well, because your expiratory pressure on your bilevel is what splints your airway to prevent the obstruction. So to me, that's a win-win for patients. So I'm definitely a patient advocate, and I get excited if we find out, wow, so we're treating you for your cardiovascular disease, we're treating you because you have hypertension, but we find out you have OSA too. We can take care of you in many different ways. When we talk about auto-set therapy, there's devices out there that a physician can say, well, they are severe sleep apnea on their back. So when you lay on your back, you're more likely to snore, you're more likely maybe to have the tissue in your neck kind of soften and collapse. So you've got that obstructive sleep apnea. It takes a higher pressure to keep your airway open when that's occurring. So maybe you need that higher pressure when you're on your back, but when you're on your side, not so much. You're not snoring, your airway's open. So auto-set pressure devices can go up and down, and it can go up and down. Your doctor sets the parameter of pressure. So if it's a CPAP, it can go from 5 to 9, or he can have it go from 5 to 15, whatever the highest pressure is that you need when you're the very worst. Or in REM sleep, they talked about that earlier. During REM sleep is when your body's paralyzed, just your diaphragm is working, so you need to have some help maybe to keep that airway open. Your muscles are very relaxed. We see it a lot now, bariatric surgery patients, auto-set, positional apneas. Sometimes it's hard. How many of you have actually had a sleep study in a sleep lab? Has anyone had that? Oh, lots of you. And so they say, come in, we're going to hook you up, we want you to have a great night of sleep. And then they hook all these electrodes to your head and all these wires to your body. And then they tell you, and we're going to be watching you all night. Okay. Just relax. Like, okay. And just breathe naturally. Okay. Oh, I can't fall asleep. I can't fall asleep. Sometimes that happens. So if you're not asleep, we can't see what you're doing and we can't get the right pressures. So those are called incomplete. They're hard to read. So that's another option for a physician to have an auto set. There's all types of devices out there. You just want to ask, if you are on an auto device, find out. Whoever's setting you up on that device, they should know about it. And different devices treat different things. So in other words, they react differently to apneas. They react or respond differently to snore. So they're just a little different. Just real quickly, just let you know, our auto sets do respond breath by breath, and they're preemptive. So we try to keep the airway open and prevent the apneas from occurring. Once your airway's closed, we can blow all the air in there we want to. The higher air we blow in, chances are we would wake you up. So if your airway does collapse, then we wait until the end of the apnea, increase pressure to prevent the next one from occurring. We do have central sleep apnea detection on our CPAP devices now and our auto sets. What that means is it's going to tell the doctor. He can get a download after you've slept on it. He can look at it and see, okay, well, we took care of the obstructive apneas, but no matter how much CPAP pressure you blow on a patient, it's not going to take care of central apneas. Your airway is already open, right? So how it works is it's kind of like radar. And I know all about radar because the popo love me. And when I'm going down the road and I see their radar guns, I'm immediately thinking, I'm looking, right? Because I know his radar works. He shoots the signal out, he hits my bumper, it sends a signal back that goes, go get her. Yeah. So that's the way our central sleep apnea device works. It shoots little pulses of air. If your airway's closed, it's like, okay, the signal's not going through and it's kicking it back. We've got an obstruction. If the airway's open and is shooting through, it just keeps on traveling, right? So it's very simple. and it does work. It's very accurate. It's got clinical proof. Then the doctor can see, you can see, oh, look at this. It took care of my obstructives. I am having central sleep apnea. And then we need to talk about a different type of treatment. We have the bi-level auto set. Real quick, I'll go through that. And it just responds to flow, snore, and apnea. Same algorithm as our CPAPs go through. But again, breath by breath, but it gives you we call it a sine wave or an ocean wave. So when you take a breath, bi-level, when you saw Angela's pictures, that you had the inspiratory pressure and then it dropped. So on the easy breathe on our device, it's more of an ocean wave. So it's more like you normally breathe. I kind of demonstrate with people. I'm kind of a visual person myself. So I say, well, what's normal about breathing bi-level therapy? Traditional bi-levels, ours included, you would have an inspiratory pressure. So I breathe in, hold the breath, breathe out. And then I'm going to breathe in, hold the breath, and breathe out. With ours, it's more natural. So that's not normally how you breathe, so why would you want to feel like that in sleep? So you can actually have it in the sine wave form where it's breathing in. And how do you breathe in? Gradually, and then you exhale. It's not, right? Okay. When we talk about central sleep apneas, we're in a whole different ballgame. So no matter how much pressure, again, you blow in someone's airway, that's not really going to help you take a breath. Traditional bi-levels, we have that backup rate that Angela was talking about. That's great. And that's what we need for most of you with hypoventilation. That's exactly the therapy you need. One other type of therapy is for heart failure patients that have centrals, but they're not having hypoventilation issues. We can treat them with adaptive servoventilation. So in other words, this is our area of, we definitely can treat central sleep apnea. You heard him talk earlier today about Cheyne-Stokes respirations or periodic breathing. This therapy is what this is designed for. It basically works on a 3-minute moving window. So you can see you're having flow here. When the patient starts to decrease, they're going to have a central. It automatically picks up and kicks in and gives the added support the patient needs until they start breathing on their own again correctly. And then it backs off. We measure in minute ventilation. So we look at the amount of air you're breathing in. You've heard of the term tidal volume, amount of air coming in and out of your lungs in one breath. Well, we look at your tidal volume times your respiratory rate, and that gives us the minute ventilation. So the amount of air you're ventilating in a minute. We don't want to overventilate you, so we say, well, we want to figure out what your normal minute ventilation is. So we calculate you when you first start breathing on the device. First 4 minutes, the device is learning your respiratory rate and your tidal volume. It's calculating out your minute ventilation. And then it says, okay, we're ready to go. And now the rest of the night, it's going to monitor every breath, and it's going to make sure that you stay at 90% of your normal minute ventilation. So in other words, when your brain forgets to tell you to breathe, it actually kicks in and gives you that support and breath that you need. It is breath by breath. It has that 3-minute moving window is actually adding a second and dropping a second over that calculation period. So during the night, in different periods of sleep, different stages of sleep, your breathing rate will change. Your normal minute ventilation changes during the night. So the device changes with you. So I think in a nutshell, that was a quick and down and dirty of algorithms. So we've given you brain overload. We've got that one continuous pressure, right? We have auto set, which would be a varying pressure for CPAP. We have the bi-level pressures. We have an auto bi-level, so it keeps you at the set inspiratory and expiratory pressures, but it moves up and down during the night to treat your apneas. And then we also have treatment for your central apneas. When we come to the mask fitting, this is my favorite part. Number one compliance factor is poor mask fit. And I don't care, I slept on CPAP for 9 years, so I would say I was a pretty good, I can speak for it's not natural to have to hook up a mask and a tube to your face. So it does need to be comfortable, or else what? You don't want to wear it. No matter how bad you feel, it's hard to get ready to sleep at night if you're like, oh, great. And if you have leaks, when you were talking about the leak and the dry mouth, if you're wearing a nasal mask and maybe you're suffering with dry mouth, maybe you are breathing through your mouth and you need a full face mask to help cut down on that. Maybe you need more pressure. Did you know a lot of times you just need more liquids in your body? So medications, different medications affect what you can have. Now, if you're on a fluid restriction, I should have done a disclaimer. Anything I say does not supersede what your doctor tells you. But it's something to think about. A lot of times we get busy and sometimes you think, oh yeah, I drink a lot of water. Oh, I didn't the last few days. I've been doing other things. Well, couple that with a medication that dries you out, you are going to have problems when you sleep, no matter how much we turn up the humidifier. So you do need adequate humidification through your nose, through your CPAP humidifier, bi-level humidifier, but also through what you drink every day. Poor mask fit can lead to, did you realize you can get eye infections and not only be annoyed by the air blowing in your eyes all night? Can cause sinus infections. You can have all kinds of problems. If you tighten it down too tight, you start getting a mark. Have you ever been in the grocery store and seen someone with a mark? Right? So I saw a lady about 6 months ago in the grocery store, and I just wanted to run to her and say, oh my gosh, come to my trunk. Let me help you. I think I can help you. Because I knew if I could see the mark at noon, that lady had her mask way too tight, and she was uncomfortable. We want to make sure when we're fitting the mask that we're fitting it properly. Now, I've worked with a lot of different masks. There are some great masks on the market, and it is knowing the mask that you are wearing or knowing the mask that you're putting on your patient and what are the guidelines for that mask for sizing. I don't care how long you've been doing it with patients, you should always use a sizing guide or a template to size your patients. So if someone is sizing you, I have respiratory therapists, a lot of my friends, of course, right? I've been in the field forever. And they're like, oh, I don't need a sizing guide. I can eyeball it. Well, you know what? I can kind of eyeball it, but it's just better to use the template because every patient's different. So use the template and make sure you're getting the patient the right size. So now I'm speaking to those new respiratory therapists that I met earlier. You want to make sure it's a good fit. With our masks, they are designed to be a very, very light seal on the face because where are your most tender pressure points on your face? Here, on the bridge of your nose, so you can get breakdown. If you're wearing a full face mask, you're also very tender right here. So we designed the mask, the full face mask, to sit more on this part, my meaty part. I call it a cheerful face, someone call it chubby, but there's more support here, okay? So we've got to make sure we get it on and we don't get it so tight. If you're waking up with marks on your face in the morning, it's too tight. And it might be the wrong size. It might be the right size. It could be that you washed it last night, it got dry, you put it back together in a hurry in the dark, and you had it on upside down. And don't laugh. I've seen patients come in and go, this isn't working for me anymore. But that's complicated. There's a lot of straps sometimes, and they legitimately had just turned it around and it wasn't working anymore. Cleaning the mask at home. Obviously, your home care provider should always give you their instructions and tell you what's cleaning. This is the bare minimum. So every day, no matter how good you wash your face at night before you go to bed, right, you're going to have body oils, some more than others. So it's always good to wipe it down. Clean your mask with warm soapy water at least once a week. It's great to disinfect it with vinegar water, or maybe you have a solution your home care company provided for you to clean it. If you have a cold, do not use your mask over and over without washing it. So just think it's a hassle. I wash it every week, but I just can't do it every day. But if you have a cold, that's the one thing you do want to wash it every day. Same thing with headgear, needs to be washed. Hopefully a minimum of once a week, but we'll see. What do you use on them? First of all, there's even liquid dish soaps that you would not want to use. So like Dawn, okay, it's got an abrasive in it that'll break down the material. And as the material breaks down, you're not going to get an effective seal, so you're going to start having more leaks. If you use things like vinegar or bleach, not good. Anything that has a strong odor, unless that's just a smell you really like, you don't want to have your mask soaking it, because when you go to bed tonight, you'll smell the bleach, or you'll smell the vinegar, or you'll smell the citrus that you used. So that can be upsetting. Don't iron the headgear. I always question, when we're out in the field working with our providers. I go out in the field once a quarter so I can stay relevant to what's going on with patients and our home care providers. And I always think, does anybody really iron their headgear? And at least once or twice a year, a provider will come back and go, yeah, I had a patient try to iron it. I was like, really? Because I'm having a hard time ironing my clothes to go to work. So, I don't know. One of the things, I heard that the Liberty was a mask of choice for several people. I've heard this over the last few weeks, and at this conference, there was some interest in it last year. I love and did love the Liberty even more, past tense. I'm going to show you a different mask. But I liked the Liberty because it was unobtrusive. So in other words, you could put your mask on, you've got the little nasal pillows, you have the mouthpiece. It's my dad's favorite mask. He's on a bi-level device. He can watch TV before he falls asleep. He can read a book. And he just doesn't feel claustrophobic. I had a near-drowned patient. As a child, she was a near-drowned patient. She came into a sleep lab for a study, and they were having a terrible time trying to get her on therapy because she was so claustrophobic. The Liberty worked for her. And in the past, before the Liberty, your full face mask, some of them can look as much like a Jason mask, or they can still be so wide here. And there's nothing wrong with those masks. There's a different type of mask because there's all different types of situations. What if you're a patient that has dentures? You don't want to tell anybody you have dentures because you're very young and for your age, and that's kind of private, right? But what happens at night when you start to go to bed and you take your dentures out? Your cheeks sink in. You start getting leaks. So there's masks. We have an older mask on the market still, the Ultra Mirage full face mask. I love that because my patients that had dentures no longer had leaks. It came out wider on the face. But with that, those masks were all over the face. Great. So we came out with a Liberty Super. Let's go. We have now what we call the Quattro FX. See if I can find my mouse and make that work. The Quattro FX has been designed. It has no forehead support. You can see there's no bar up here on the head, but it's a full face mask. It goes over the nose and under the lips, down here right in the crease of the chin. It's very lightweight. So again, the headgear to me from the side almost looks like the Liberty. Those straps come a little bit higher. The Liberty straps come right about there. But this has been a great choice for patients because, again, it comes back to patient choice. It should be your choice. Well, why? It's your body, and you're the one that has to sleep with it, and we need you to be compliant because if you're compliant on therapy, you can make a difference in how you feel every day. You can make a difference in how far you can walk to the mailbox. If you're a patient, I had a chronic obstructive pulmonary disease patient one time. He could not walk outside to the mailbox. He got short of breath going to the bathroom because he didn't have enough air, and at night he wasn't getting adequate ventilation. He got on bi-level therapy. He started sleeping better. He felt better. He was getting the rest that his body needed, so he was no longer having the problems, and now he could walk to his mailbox and back. It's all about getting comfort and feeling better, quality of life, but it also can make a difference in reducing blood pressure. You can see a difference in different areas of illness. The techniques, I'll show you quick. How are we on time? For some reason. Am I out? Okay. So we have the dual wall cushion. Okay. We're going to finish up with this. No forehead support, tension reducing headgear, so it makes it very comfortable. But there is a trick to the fit, and not as much of a trick as finding my mouse. There he is. Sorry. It's size, so we get the proper size, and then swing, and then it seals. So if you get an opportunity to try this mask, you hold it out, you put the headgear on the top, you hold it out like this. It goes lower on the nasal bridge than you would think, a little bit lower, and then you swing, and it fits into place. And it has been, by far, I have started to see our patients that love the Liberty love the Quattro FX. And I believe we have a Quattro FX on the table out front. Okay. All right. So just to finish up, I'll give you time if you have any questions. I appreciate you being here most of all. For those of you that wear this every night, don't be afraid to speak up to your home care providers or speak up to us at the table if we can answer questions. But the most important thing is that you find what works for you, and then you can do what your doctor is prescribing and get the benefits. Any questions? Thank you.
What kind of mask will be available for us who have glasses that want to read in bed with our BiPAP mask on?
So the Quattro FX, my mom wears, and she wears glasses in bed. If you don't have to have full face mask, if you only wear nasal, we also have this mask in the nasal now as well, so it's very, very petite, glasses easily. The Liberty and the Quattro FX are the two full face masks that you can easily wear glasses with.
And if you can do with nasal pillows, the Swift FX for her allows me to wear my glasses, and I just love it. So it's worked out really well for me.
Okay, so yes, any of the nasal pillows, no matter who the company is that manufactures it, nasal pillows are great for glasses. I personally could never wear the pillows because I couldn't handle that much pressure in my nose and my sinus. It bothered me. So I missed out on that, but absolutely, if that's a choice you could make, yes. Any other questions? Okay, if I can say one last thing, I am the person, for those of you who need continuing education credits, I'm the person that has your certificates out front. So come to the table and see me. You need to make sure you signed in on my special sign-in sheet for the CEUs that the accrediting agencies require. I need your program evaluation, and then I'll hand you your certificate. Thank you.